history is 56-year-old female, homemaker, used to work as a cleaning staff in soda factory. Complaints of joint pains, abdominal discomfort, heartburn, painful ulcers of fingertips for past 3 months. 56-year-old female patient.
Yes.
Joint pain and abdominal discomfort. And heartburn, painful ulcers of the fingertip. So it can be vascular disorders, chronic history of complaints of joint pain.
How do you analyze joint pains?
So, whether it is the site of the pain, whether it is axial or appendicular, then it is inflammatory or non-inflammatory, and the joints which are involved, then the type, like whether it is whether there is any morning stiffness or not, then whether it is
morning stiffness indicate to you?
It means that there is osteoarthritis.
Morning stiffness is indication that you are dealing with a case of inflammatory disease. So this patient had morning stiffness. So carry on with the rest of the history. What do you think?
Then abdominal discomfort, heartburn are also there. Painful ulcers at fingertips. Painful ulcers at fingertips means there will be some peripheral vascular disease, because the perfusion.
Fine. Can you analyze the abdominal part?
Abdominal discomfort and heartburn. Peptic ulcer disease.
So can you?
3 months.
What does heartburn indicate?
As a peptic disease.
Has come to your esophagus.
GRD.
So GRD. So can you put the inflammatory pain, GRD, and painful ulcers of fingertips, and come to a differential diagnosis where gastrointestinal system is affected?
If there is any motility, esophageal motility.
So if it is present, what will you suspect? What else?
Raynaud's disease.
Raynaud's disease. Okay. Raynaud's disease is different from Raynaud's phenomenon. They call primary Raynaud's disease, secondary Raynaud's phenomenon. Okay. So what is the difference diagnosis of painful ulcers in the fingers?
Raynaud's ulcer.
Yes.
And if there is poor blood flow to the, in any cases where there is when any infection, then
poor blood flow, infection. Good. What are the cause of poor blood flow in a 29-year-old female?
If there is in Raynaud's phenomena, if there is vasoconstriction, then in cold, then the blood flow will be low, and it can subsequently develop in painful ulcers due to vasoconstriction.
Good. Can you name some connective tissue disease where you have painful ulcers in the fingertips?
Scleroderma.
So can scleroderma patient have GRD?
It can, sir, because if lower esophageal sphincter will be.
What do you think? Can this be case of syringomyelia?
Yes, sir. uh, in syringe.
Syringe, do you get ulcers?
Yes, sir.
Are they painful?
It is painful, sir.
It is painless. In
Painless.
so they are painless ulcers, yes. So your vasculitis, vasculopathy. So this patient got multiple large joints, small joints, bilateral with morning stiffness, swelling, heartburn, reflux. Okay, this is the history of this patient. So how do you make out a diagnosis here?
Sir, female with the scleroderma.
Okay, can SLE have ulcers in the fingertips?
SLE also can have vasculitis.
What about conditions where you can have thrombophilia? You can have. What about condition where you can have occlusion of a blood vessel?
Yes, sir.
You can have. So special past history is
Type 2 diabetes mellitus and hypertensive for 10 years. 3 years back, there is a history of swelling, pain of arms and legs, followed by tightening of skin over arms and legs, swelling and redness of face and sun-exposed areas, leading to tightening of skin, pain, swelling of multiple large joints, bilateral, hyperpigmentation and patches of hypopigmentation of skin, and difficulty in swallowing solid food.
What do you make out?
There can be a case of scleroderma.
What is the characteristic pigmentation of scleroderma?
Hyperpigmented.
It will be a combination of salt and like appearance. So we have got skin tightener here. So what are the conditions producing skin tightness?
Scleroderma, then systemic sclerosis, then diabetes mellitus.
What is the characteristic hand appearance of diabetic hand?
Coffee.
What sign you can elicit in skin tightening seen in diabetic patients? You get what's called as prior sign. Diabetic uroarthropathy. Okay, so you had some skin changes in HIV. Can you enumerate some skin manifestations of HIV infection?
There will be ulcer and lipoatrophy. Then there will be fungal infection. Then pruritic papillary eruption.
Good.
Then
you get scabies,
eczema,
Norwegian scabies. You may get
Norwegian
a rash
crusted.
even at time of seroconversion. You may get measles like rash. You may get rash of syphilis. You may have Kaposi sarcoma, molluscum contagiosum, tinea of all different types, multidermatomal herpes zoster. You may get thrush anywhere. You may get different types of warts, herpes simplex. So varieties of skin changes are possible in retrovirus infection. Radiation is another one where you can have a lot of skin tightening. Now tell me something about graft versus host disease.
So, it occurs in allogenic transplant. Then it is can be present with skin rash if the on the redness on the area of the skin.
What is meant by acute graft versus host disease, caused by persistent, recurrent,
acute,
or late acute. Okay.
within 24 hours of the graft, in acute graft versus host reaction may be within hours of graft, and then there will be reaction.
In acute variety, it is within first 100 days, and more than 100 days this is chronic, and there may be some acute presentations later than 100 days. They are called as late acute. This 100 days cutoff is important, and 3 areas where these manifestations are seen, you rightly said. One is skin, other areas, one is G80, and third one is the liver. Okay, coming to the puffy fingers, what are the differential diagnoses?
Puffy, multi system connective tissue disorder, then acute
mixed connective tissue disease.
Mixed connective tissue disorder, then acute phase of systemic sclerosis and dactylitis.
Name some causes for dactylitis.
In
Gout, sarcoid, spondyloarthropathies. Okay.
Yes.
So you can have dactylitis. So sarcoid, gout. So
yes.
Okay, psoriasis, whatnot. You can have. And this particular patient had following findings:
pallor of fingers and toes on exposure to cold, bluish discoloration, redness and pain, painful ulcers over tips of fingers, tightening of skin over fingers, history of progressively worsening dyspnea on exertion, currently even on daily activities associated with the dry cough. It can be Raynaud's phenomena.
Classical French tricolor pattern: white, blue, red, and so on. So this is a very classical description. Then how do you get this dyspnea?
Interstitial disease here.
One possibility is interstitial lung disease. Second possibility is that the skin is tight even on the chest. There may not be
So
much
chest wall expansion won't be there.
These are the findings. Describe.
Examination. It is moderately built and nourished. Pallor is present. Bilateral thickening pedal edema. Vitals, pulse rate is 74 per minute. Peripheral pulses are present. BP is 130/60 mmHg, and respiratory rate is 24 per minute. He is febrile. The patient in the we can see the salt and pepper appearance of the skin, and digital ulcers also.
Can you see pitted scars?
Yes, sir.
Yes, so very classical for systemic sclerosis. Okay, so skin or the face, arms, legs, shiny, tight and taut. What do you mean by that?
That it is underlying edema.
So how do you classify? How do you classify systemic sclerosis? It can be limited variety or it can be diffuse variety. So here it has gone up to the chest wall, face, arms, legs. So it has gone up above the elbow. So this is a diffuse variety. So inference is prognosis bad.
Yes.
So if it is limited variety, renal involvement will not be there, unlikely. Interstitial lung disease is unlikely.
Yes.
Cardiac manifestations may be there in diffuse variety, may or may not be there in limited variety. Digital ischemia, on the other hand, is more common with limited variety, but occur in diffuse variety also. Pulmonary hypertension is very common with limited variety compared to diffuse variety. G80 manifestations can occur in both. Polyarthritis is rare in limited varieties, common with systemic sclerosis as in this patient. Weight loss and malar rash can occur with the diffuse variety. Raynaud's phenomenon is very classical for limited variety.
Limited varieties.
Okay, other one may be present, may not be present. So can you briefly tell this G80 manifestations?
So there will be the LDS lower esophageal sphincter will be lax, so the as GRD will be there, causing heartburn as in this patient.
It affects the all parts of the G80, starting with the mouth. Size of the mouth will be less. Normal size of the mouth.
3 fingers can be inserted.
That's right. So microstoma is very characteristic, giving the characteristic appearance of face in these patients. And they can have constipation alternative to diarrhea. There will be stasis of contents of the small intestine, and there can be overgrowth of the different bacteria. There can be pseudo obstruction. Okay, severe bowel distension and rupture can occur. So multiple things are possible in the intestine of these patients. What is Rotten scoring system? The scoring system to quantify how much area of the skin is affected. So in this case, this chest expansion is only 1 centimeter, and bilateral crack is central.
Trachea is central. No drooping of shoulders. Movements of chest wall is reduced. Chest expansion is 1 centimeter. Breath sounds equal bilaterally, and fine repetitions bilateral infrascapular and left infraxillary areas. So, sir, the patient might be in interstitial lung disease, and
okay, what are the differential diagnosis of bilateral basal crackles?
Congestive cardiac failure.
Left heart failure, yes.
And then interstitial lung disease.
Very good.
And
bronchitis.
Bronchitis.
So G80 they can be very manifested. Serious findings.
G80 is not visualized. S1, S2 heard. Normal S2 normal split. No murmurs. No S3, S4. No palpable P2 or parasternal pain. Nervous system within normal limits.
So we expect some pericarditis. We expect some heart blocks, myocardial fibrosis, pulmonary hypertension, right heart failure. So everything is expected. What's your complete diagnosis in this case?
Systemic sclerosis with Raynaud's phenomena, limited.
When one goes up to the arm, it goes away from limited to complete diffuse variety. Okay. What investigations you plan in this case? Anemia. So we have to look for anemia.
Hemoglobin.
Malabsorption state. So it can be dimorphic. There are multiple deficiencies. It can be iron deficiency alone. It can be B12 deficiency, or there can be overgrowth of the bacteria producing B12 deficiency. You can have any pattern of microangiopathic hemolytic anemia is possible if the patient is in renal crisis. ESR, what do you expect?
ESR will be raised.
Okay. And the urine examination may show proteinuria. And what antibodies you are specifically looking for?
SSC associated autoantibodies.
So you specifically ask for SCL70. That's antibody against topoisomerase 3.
Yes.
Which can occur in both conditions, both limited and other variety. If you get anti-syndromere, it's more specific for limited variety. And if you get anti-polymerase 3 antibody, it indicates that this patient is likely to have diffuse variety and chance of renal crisis is very high. You have to go for X-ray chest. You have to confirm it is interstitial lung disease by CT, HRCT. You have to go for a ABG. You have to look for pulmonary function test for restrictive airway disease, and then you have to look for DLCO. Okay. And since fingers are affected, the extra hands may also be useful. So you have to check for urea and creatinine also. So renal crisis is possible. So this particular patient, these things are all normal, and these are the X-rays. What do you find? Normally, terminal phalanx will be having what's called as a particular appearance. It will taper. Terminal phalanx will taper. When there is resorption of the terminal phalanx, you can see the picture below. With one single finger, it is all resorbed. So it will become a horizontal line. So this is the resorption of the terminal phalanx. Phalanx can be seen. Okay. So chest X-ray did not show much, although there was evidence of crackles that will be made out by HRCT. Echocardiogram was basically normal. No features of pulmonary hypertension. So this particular patient, you already said a diagnosis. Now tell me what significance of telangiectasia. Few telangiectasia were there. What is its significance?
The vascular involvement.
The number of telangiectasia is proportionate to the chance of becoming pulmonary hypertension. So what are the causes of ulcers in the fingertips in systemic sclerosis?
It's poor blood flow, vasoconstriction.
So ischemia is 1, Raynaud's phenomenon is 2, infection is 3, calcinosis is 1, contractures is next one. You can have ulcers in the GI tract also in these particular patients. Why do you get interstitial lung disease and pulmonary hypertension? You are rightly said this patient is likely to get aspiration that can predispose for interstitial lung disease. Persistent hypoxia is another reason. And pulmonary hypertension, hypoxia producing vasoconstriction. Alternatively, there can be direct involvement of the vessel producing vasculopathy. So what is the basic principle of treatment of these patients? How do you treat these patients?
We have to first diagnosis. We have to arrive at a diagnosis. When any internal organ is involved or not, then we have to arrive at diagnosis whether the disease is localized or diffuse, the activity, then we have to see whether the response to the therapy. And
that's right. So her complaint is mainly for GI tract. So you treat GERD. One aspect is that. Secondly, she is saying about a Raynaud's phenomenon. So you give her gloves, mittens, calcium blockers, and phosphodiesterase enzyme 5 inhibitors or elioprost can be given intravenously, very severe. If there is malabsorption, you give her antibiotics, and if there's a crisis, you give what drug?
steroids.
Crisis, you give them ACE inhibitors, even if the creatinine is high. If the predominant myositis, what will you do? You have to give them steroids. If there's skin involvement, you give them methotrexate. Lung involvement, you give cyclophosphamide or MMF. And if there's a pulmonary hypertension, what drugs you give? You have got sildenafil. Bosentan. Very good, very good. There is Bosentan. Okay, what is crust syndrome?
The 5 features are there: calcinosis, Raynaud's phenomena, esophageal dysmotility, then sclerodactyly, and telangiectasia.
Very good. What is systemic sclerosis crisis?
In accelerated, it is in scleroderma patients, the accelerated hypertension and acute AKI and failure.
Very good. So, how do you recognize this entity? What's the recommendation for you? Every month they must have BP checkup done. If blood pressure tends to go up, and if the creatinine is going up, you had suspect renal crisis and start the patient on ACE inhibitors.
ACE inhibitor.
What are the predictors of renal crisis? Couple of predictors. One is if there's too much exposure of cold exposure to the patient, they can precipitate it. If by accident they become pregnant, there can be a problem. If you use steroids for these patients, they may occur crisis. So steroid use should not be entertained in patients with systemic sclerosis. And dehydration is the fourth problem coming to these patients. And when you find that the skin problem is rapidly developing all over the body, remember the patient is going for renal crisis. And when you examine these joints, if you find tender friction rubs, then that's again a bad sign. And one particular antibody, anti-RNA polymerase 3, is again speaking for systemic sclerosis crisis, renal crisis. So the important message for these patients is, if you have a patient with systemic sclerosis, you can increase the life expectancy by checking for renal crisis and taking care of them. And meanwhile, you can specifically treat these patients directed to each organ which is affected. There is no single drug which can cure these patients.
Yes.
Okay, thank you. Any doubts about this patient?